Bowel obstruction after Roux-en-Y reconstruction can occur secondary to variety of etiologies. For most common etiology in the decreasing order of frequency are internal hernia, adhesive obstruction, stenosis at jejunostomy site, and incisional hernia. Herniation through the mesenteric defect graded by jejunojejunostomy or herniation through the mesenteric defect in the mesocolon can be the cause of the internal hernia. Welcome to our channel, viewers. This is 14th video tutorial in our this digital learning, and we are very thankful to the response we have received from the viewers, and that will help us keep going, and we'll upload more educational videos. In this video tutorial, we have talked about stapler assisted jejunojejunostomy, and it has been designed. The video tutorial is designed a way that even a first year surgery trainee who is doing his first jejunostomy will be able to do it confidently after watching. The main indication for jejunostomy will be Roux-en-Y bypass. Roux-en-Y bypass may be required after gastrectomy, that can be total, distal, or proximal gastrectomy, or after GE Junction tumors, or biliary bypass that may require Roux-en-Y hepaticojejunostomy after Whipple procedure. It can be part of the esophageal reconstruction technique in which the jejunal limb is used as a replacement for the esophagus, or as part of Roux-en-Y cystojejunostomy for height cyst or pseudocyst. So mainly there are three types of jejunostomy. One is entirely sutured, that is hand sewn. Another is entirely stapled, in which we will use two staplers for creating the side-to-side jejunostomy. Or third is combination of two technique, that is the highlight of this video, in which we do side-to-side linear stapled jejunostomy and will suture the common enterotomy site. It is helpful that it is economically more viable. So what are the key steps for jejunostomy? One is it should be anti-mesenteric position of the anastomosis. Second is we should avoid ischemia at the stapler line. The stapler line should be good, should have good vascularity. And with each technique, care must be taken to adequately close the enterotomy while not narrowing the anastomosis. A word of caution is here that we should always check for the intraluminal hemorrhage from the stapler line. Otherwise, if missed, it is very difficult to diagnose in the postoperative period as the blood keeps trickling in the lumen of the bowel. So, stenosis and jejunojejunostomy, it is a quite rare, and it is usually related to the technical error or adhesive disease. Symptoms of jejunojejunostomy include bloating, early satiety, unexpected weight loss, and abdominal pain. Coming to the case details, the index case was a 64-year-old lady with a recurrent giant height cyst in the liver, right lobe of liver, with cystobiliary communication. In this case, we did Roux-en-Y cystojejunostomy and jejunojejunostomy. We have already talked about management of giant height cyst in another video tutorial, the link of which I will share in the description and in this video also. So in this video tutorial, we have demonstrated in detail the technicalities of side-to-side stapler-assisted jejunostomy. So after doing the Roux-en-Y cystojejunostomy, now we have reached the part of doing stapler-assisted side-to-side jejunostomy. The first part is we align the two limbs of jejunum correctly. But I leave up to the viewers. They won't or they may not do the same thing. So coming to the mesenteric defect at jejunostomy, this text I have taken from the Mastery of Surgery. The 12 bariatric surgery center in Sweden, more than 2,500 patients randomized their time surgery to closure of both the jejunostomy defect and Peterson space or no mesenteric closure. At 3 years after surgery, the cumulative incidence of reoperation because of small bowel obstruction was significantly reduced in the closure group. That is, mesenteric closure group has lesser chance of small bowel obstruction in long run. The cumulative probability was 0.055 versus 0.102 for non-closure, and it was statistically significant. In the same study, the author measured that the closure of mesenteric defect increased the risk of severe post-operative complication 4.3 versus 2.2 for non-closure, and that is the early complication because the jejunostomy were higher in the closure group. But the author concluded that the study endorsed the routine closure of mesenteric defect in laparoscopic gastric bypass surgery, but that closure of the mesenteric defect might be assured with increased risk of early small bowel obstruction caused by kinking. For Roux-en-Y reconstruction, the genuine divided 30 cm distal to a ligament trees using a linear stapler that can be double or triple row, as I said, and it is based on the third arcade. This is followed by creation of 40 to 50 cm or maybe up to 60 cm defunctionalized Roux-en-Y limb with side-to-side jejunojejunostomy. Bowel obstruction after Roux-en-Y reconstruction can occur secondary to variety of etiologies. For most common etiology in the decreasing order of frequency are internal hernia, adhesive obstruction, stenosis at jejunostomy site, and incisional hernia. Herniation through the mesenteric defect graded by jejunojejunostomy or herniation through the mesenteric defect in the mesocolon can be the cause of the internal hernia. CT is the initial test during workup of a patient experiencing symptoms of internal hernia, and radiologist experience in the analyzing Roux-en-Y anatomy should be available. The characteristic CT signs of internal hernia are changes within the mesentery, most notably swirling of mesenteric vessel. The mesenteric swell sign recognized with the internal hernia and mesocolic defect created by mesenteric vessels. Other CT findings suggestive of internal hernia are small bowel obstruction, jejunum passing behind the superior mesenteric artery, jejunojejunostomy located in patient's right hemiabdomen, normally should be in the left side, and clustering of small bowel within one quadrant of the abdomen. Abdominal pain out of proportion to examination requires exploration to rule out presence of internal hernia even in the setting of normal imaging studies. First aim of operation is not identification of potential spaces and or hernia. Instead, identify the terminal ileum and perform a retrograde exploration of small bowel back to the ligament of Treves and gastrojejunostomy, hepaticojejunostomy or cystojejunostomy. By performing the distal to proximal examination, the surgeon will reduce the internal hernia and may notice a visible difference in the appearance in bowel color and caliber during the exploration. When the entire small bowel has been examined, the potential mesenteric defects need to be inspected. So, in case we are dealing with a case of obstruction after Roux-en-Y bypass, so we should not try to identify the hernias. Instead, we should try to examine the gut from ileocolic junction and come retrograde. That will help us in us to identify the hernia and reduce it also. Thanks for watching, viewers. Hope you like the video. Please don't forget to like, subscribe and share the content. We wish you a safe and complication-free jejunostomy once and always. Happy learning. Thank you very much.